Dobro ranko, drodzy takoleche. I'm Dr. Andre Turon, all the way from beautiful South Africa. I hope you're ready this morning. We're going to jump right into regional anesthesia for the shoulder girdle surgery. Now, as part of this, I always do some functional anatomy because if you don't know the anatomy, you don't know what you're blocking. Then, specifically, going to show you lots of these blocks, and that will be the interscalene, superior trunk, suprascapular nerve, both the anterior and posterior approaches to blocking it. Then the axillary nerve block, the infraspinatus teres minor fascial plane block. This is a new kid on the block to block. And then the pectoclavicular plane block. These are two very new blocks, and I have found lots of joy with them. So let's get started. First, this is a wonderful picture that you have all seen and you all know. We're going to start off at this area, working with the nerve roots. C5, 6, and 7 are the most important ones for us in the shoulder girdle area. Then we're going to move to the trunks, upper trunk, where the suprascapular nerve is one of the biggest components. And then as we move down, remember the anterior and posterior divisions. We can't block at that stage because it's behind the clavicle. Then lower down, we have some more important blocks. Nerves to block is the lateral pectoral nerve as well as the lower subscapular nerve. They also contribute to the shoulder girdle. Then over here, lastly, we go to the axillary nerve, and we're going to look at blocking this entire area there. Now, first things first, nerve roots. And we are specifically looking at this area. And over here, we'll be doing the interscalene block and the superior trunk block. Now, the interscalene block, this is the gold standard for shoulder surgery. It works exceptionally well. Your patients will not complain about pain whatsoever if you do this block properly. What I tend to do is to scan from clavicle proximally at about 3 to 4 centimeters proximal to or cephalad to the clavicle. You'll find the area where you need to block the interscalene. So I tend to scan from lower down and scan upwards so that I can easily see it. Then you can do an in-plane approach where you see your needle throughout the entire tract of the injection. I prefer using this method even when using catheter techniques. It is safer, and I feel that especially if you're just starting off, seeing your needle is very important. You also can do the out of plane. This is a bit more advanced. You have to know what you're doing. It is easier if you're placing a catheter. It is sometimes more comfortable, and you stay away from the surgery area. So if that is a problem for you, just make sure that you get to learn this one. So the interscalene block, what you'll see on ultrasound picture here is we have our anterior and middle scalene with the roots here, C5, and then C6 is usually a bifid, or you can have a single or a double or sometimes even a triple root at this level. So what we see is C5, C6, C6. And then it looks like a little butterfly, or some people say that looks like traffic lights, whatever you find more helpful. Then something to keep in mind, your needle will be coming in from posterior laterally through this middle scalene muscle, piercing the muscle fascia, and then outside the sheath of the interscalene nerve components. So you have to stay outside of that sheath and just pop through the fascia layer here. So you want to inject posterior about 4 millimeters away from this area, and where you pop through is between the C5 and C6, so that you do not inadvertently harm part of the nerve if you pop through the components of C6. As you traverse this muscle, remember that the dorsal scapular nerve as well as the long thoracic nerves also traverse through the muscle. So if you put your needle through there, make sure that you have nerve stimulation on, or just look out for this. It's sometimes very difficult to see. Just make sure that you look for it, because you don't want a winged scapula afterwards. Right, then moving on, here we see the schematic of the interscalene block here, with the needle piercing through between that C5 and C6 roots and injecting. You can see the posterior spread here and even up to C7 spread. Then over here we have a video of that. I will pause it here and there just to show you some specifics. So if you are scanning, this is C4 level, and there you can see the superior cervical trunk. That is C5. There we see C6. And over here, C7 roots as they come out. Now, right over there we see the phrenic nerve as it moves away, and over here it turns into the superior trunk. Right, then the superior trunk block. Why would you want to do the superior trunk? Well, as you saw in the previous video, the phrenic nerve moves more medially as it goes into the thorax itself, so it moves away from your upper trunk or your C5, C6 roots. So every centimeter that you move further distally is 8 millimeters that it moves medially. So if you want to prevent hemidiaphragm paralysis, the further distal you can block it, the better. And the superior trunk helps with that. So with this one, we again scan. You can start at the bottom and scan upwards. Just find the interscalene, and then as on this video that I showed you, remember that you can then scan down and see your as the C5 and C6 becomes the upper trunk. Now over here you see that this is the normal interscalene level, and over here we have the superior trunk level. The interscalene with the anterior scalene muscle here, the middle scalene, and there we see again our C5, C6 nerve roots, and over there that little very tiny, I hope you can see it, tiny blue arrow over there is pointing towards the phrenic nerve over here. And then as you scan a little bit downwards, I mean this is 2 centimeters, we already see the superior trunk. There's our middle trunk over here, still anterior scalene muscle, and that phrenic nerve is now right over there. So blocking the superior trunk with a small volume means that if you have that volume, it still has to go all the way around here to the phrenic nerve. So the chances of phrenic nerve paralysis becomes decreased. But remember, as long as you're blocking above the clavicle, you always have a theoretical risk of phrenic nerve paralysis. Here we just see a schematic of what I've just said. Now, moving further down, that was the first part of it, the interscalene and the superior trunk. Now we move towards the suprascapular nerve. This is probably the most important nerve to block when blocking the shoulder, because it innervates about 60% of the shoulder. On the superior, posterior, superior, and anterior superior areas of the shoulder joint itself. The suprascapular nerve, as it enters into the suprascapular notch underneath this superior transscapular ligament, right before it enters there, it branches off, and it gives off this little branch, the medial subacromial bursa branch that supplies the subacromial bursa. Now that is a very big nociceptive component of the shoulder, so that is very important for pain management, specifically to that subacromial bursa. So if you're doing the blocks, there is the anterior block and the posterior block. Posterior block would be past this ligament here in the suprascapular notch, and the anterior block would be before branching off, so somewhere in this region, and I'll show both of those to you a little bit later. Here we just see a view from the top down of that area, and you can see here again posterior component, anterior component before it starts branching off. Then here, just this, the red areas are the areas where there is a high density of nociception. So here we can see on the anterior component the subacromial bursa, and then also the ligaments between the cricoid and the clavicle itself, and the clavicle and the acromion itself. Then posterior side as well. Just to mention, over here you see the axillary nerve as it comes round the humerus. Just important, remember where these are in relation to each other, and that's going to become a little bit more important in a few slides. Then over here, this is a beautiful picture showing you exactly the anatomy of that suprascapular nerve as it comes off. So over here we see the subclavicular artery right over there, and then the upper trunk, and then that suprascapular nerve comes off the upper trunk and traverses underneath the omohyoid muscle, this little bootstrap muscle, and then it continues onward and goes into that suprascapular notch, and there we see the suprascapular notch as well as that superior transverse scapular ligament. Right over here, this is the picture that you want to see for the subomohyoid. As I said, you would like to block it underneath the subomohyoid. So you see the subclavian artery right over here. There we see the plexus, as you would with a supraclavicular block. That's omohyoid, and the most lateral component right over there is that's our suprascapular nerve, and this is the subomohyoid approach. You can very easily block this with 2 to 3 cc's of local anesthesia. You can even give up to 5 cc's, and the chances of getting a hemidiaphragm paralysis from this is almost nothing. Then if you wanted to do the posterior approach, this is how we would approach, hold the probe there, and then what we see over here, that's our suprascapular muscle. Above that is the trapezius muscle, then that suprascapular notch, and in that notch at the bottom we'll see the artery and then the nerve as well, suprascapular nerve and artery. And that is what you aim for. You aim for the artery. It's quite difficult to see the nerve in and of itself. Then posterior, we have our axillary nerve as it comes off here between the teres minor muscle and the humerus, and then it comes with the posterior circumflex artery. And this is what picture we'll see. We see the deltoid, we'll see the teres minor, and the shaft of the humerus, again in relation to that posterior circumflex artery, and that's what you aim for, the posterior circumflex artery. And you can approach it either from cephalad or caudate. It doesn't really matter which way you approach this. Then just to remember that teres minor muscle, the infraspinatus goes right over it, and this forms a beautiful plane where we have our axillary nerve as well as the components, this posterior components, to our suprascapular nerve. Now this is an exciting new block. This is an interfascial block, so you don't actually aim for the nerves, you aim for the fascia between infraspinatus and teres minor. And what we'll see there, if you can see on this picture, we'll start with the ultrasound over the humerus, the joint itself, where you can see the insertion of the tendon of infraspinatus and teres minor, and that is the little area we're looking for. Very difficult to see or find at this level. Then what we'll do is we will scan down and see that quadrilateral space, so humerus, teres minor, and then the posterior humeral circumflex artery, and then from there we scan obliquely over the muscles, and we'll see the infraspinatus, we'll see teres minor at the bottom there, and then the scapula at the bottom. And that's what we're aiming for, that interfascial plane. Just easier to see the further medial you scan. Now, why is this important, or why is this an interesting block? Well, it covers a lot of the pain of the shoulder through the axillary nerve, as well as the posterior components of the suprascapular nerve. Why don't we just do the blocks that I previously mentioned? Well, the interesting part to this is that you can actually place a catheter for longer term pain management in this fascial plane. Now, there we see the injection, the needle, as it injects the local anesthetic between those fascial planes. You will also see spread right above the scapula, right over here. So in between those muscles and over the scapula. Here we can see it as well over the scapular notch. Then over here, what you can see is a catheter placed. It was placed from medial to lateral in an oblique fashion underneath those muscles, and this can also help for better pain control over a longer period. Now, lastly, I just want to touch on this little block, the clavipectoral fascial plane block. It has brought me quite a lot of joy. I've used it several times over this year, and I think that is my block of the year for for 2023. It gives me quite a lot of joy to do that for clavicle fractures. Now, the clavicle itself has very difficult innervation, so that's why it is very difficult to block it. What I just like to show you here is that clavipectoral fascia, and all the nerves that supply the clavicle have to go through the fascia towards the bone. So this forms like a nice little sheath around the clavicle, and if you inject local anesthetic in there, it spreads over to the entire part of the sheath. You have an injection medial over the fracture and lateral. Some people say that you only need proximal and or medial and lateral to the fracture, but it depends on what you want to achieve and how much volume you want to see. So over here, please go look at this. I'll show it to you a little bit later on. Regional anesthesia, it teaches you how to do this block perfectly. So what we see is that sheath from the pectoralis minor, and it envelops the clavicle here, and there we see pec major. That's subclavius. Your needle will come in and just pierce through that sheath, and as you inject, it will spread everywhere in that sheath. This is the placement of your probe and of your needle, and it will be medial and lateral to the fracture. And this is the picture you'll see. This is the clavicle itself. Pec major is over here. Pec minor would be a little bit further, and subclavius in this region. You don't specifically need to see them. You aim towards the clavicle itself, and then as you scrape over that fascia, when you start injecting, you will see, just like over here, you'll see your local anesthetic spread around here and even down that side. And as I said, medial on the fracture and lateral, or just medial and lateral. To that, you'll just have to divide the volumes a little bit better. And that's all from me. I hope that you will use some of these blocks, and you will look at the shoulder girdle anatomically when you think about the blocking. Now, this is that website I told you about for the clavipectoral plane, and there's lots of other blocks that you can learn. Please go look at it on YouTube. Regional Anesthesia and Acute Pain Medicine. Jeff Gadsden, a wonderful guy from Dukes. He is leading this charge, and he explains it beautifully. Then also Block It Like It's Hot if you want to learn about blocks as well, and hear discussions from Amit Power and Jeff Gadsden. They have a podcast, beautiful to listen to, and lovely information that they give there. And lastly, but not least, is the Nizora Nerve Block Manual. It's just come out for Christmas, this deluxe edition. If you want to get that for yourself for Christmas or tell somebody else, I don't know whether they'll deliver, but you might get it at some stage. And then obviously the app, very useful. Hope you have a wonderful course, and I hope that by the time we get to the next one, I will be there in person. Have a lovely day. Bye for now.